Well, like a lot of individuals, I was an athlete and participated in a lot of sports growing up. And of course, with that, I had my own share of injuries and actually had some experience visiting orthopedic surgeons growing up. And so I know what it's like to be an athlete and to be injured and be told that you will not be able to continue on in your career, your activities. And so I had a really great orthopedic surgeon and ended up being a mentor for me. And so as I entered into college and really became interested in sports medicine and started off as an athletic trainer and a trainer in a gym, and then really focused on sports medicine, orthopedics for me was an area of medicine where I felt like we really were able to actually cure things and actually get people better. Orthopedics is one of those fields where someone injures something like an ACL or tears a cartilage, that we can actually cure that, go in and give people their career back. And so for me, that's very rewarding, of being able to actually solve a problem and help people to remain active. With respect to coming to North Texas and practicing here, I think that even USA Today has looked at North Texas as being one of the greatest places to raise an athlete in sports medicine. There really couldn't be a better area in the United States, I feel, in order to practice what we do. Certainly lots of athletes that participate in all sorts of sports, everything from soccer to football. And so when you realize as a father and as an orthopedic surgeon the opportunity to take care of athletes, it's really a privilege to be able to care for them with their physical injuries, and also be a mentor and support many of those young athletes has also been very rewarding for me. One of the things that happens in orthopedics, and certainly with orthopedic injuries, is that being a parent, when someone gets hurt on a Friday night or Saturday football game or soccer game, and really a parent is left with the choice of, what do I do? Where do I take my loved one to find out if it's really serious or not? And up until now, for the most part, parents were left really with the option of taking them to an emergency department, which is going to be fairly expensive. And you're seeing someone that's not an expert in musculoskeletal care. They're going to likely x-ray you, examine you, maybe put you in a splint. You're not getting to the diagnosis, which sometimes can delay the appropriate level of care and cause problems down the road, and then ultimately send you to me anyways. So with the orthopedic urgent care model, much like what happened in family practice and urgent cares many years ago, when people were sick, if we look back 20 years, they usually called up their primary care doctor, and when they were sick, I want to be seen today. And often busy offices would say, well, we can see you in a few days. Well, of course, when you're feeling bad, you want to be seen today to get relief. And over probably the last 20 years, we've seen a move in primary care towards urgent care. For the most part, I think patients now, when they're not feeling well, usually don't go directly to their primary care. They'll often go to an urgent care where they get seen and they get treated when they're sick, get relief, and then for busy people, get back to their lives. In orthopedics, the orthopedic urgent care is a paradigm shift, and we feel that we are actually offering a unique delivery system that has not existed in Texas so far. And so with that model is allowing patients to come in to be seen by an expert in musculoskeletal care. It'll cost them less, and they're actually getting the definitive and appropriate care faster, which hopefully will help them to get back in their game sooner. Well, I think for anybody that has an injury, seeking out the most experienced person to take care of that injury is always a good thing, no matter what the problem is with our health. In our practice, we have very experienced individuals, myself, who have advanced training in sports medicine. A lot of the public may not be aware that there are orthopedic surgeons out there that may do similar things but don't have the advanced training or fellowship training that I have. What fellowship training is, for those that don't understand that, is an extra year or sometimes 2 years of training after an orthopedic residency. So someone goes to medical school and then does a 5-year orthopedic residency and then can go into practice and do a lot of the procedures that we do. As a fellowship-trained sports medicine specialist, I have additional training beyond what the average orthopedic surgeon has, focusing on those types of cases that we specialize in. And even after fellowship training, I have gone on and participated in research, certainly done advanced courses in cartilage transplant, minimally invasive joint preservation procedures, and then with my practical experience of 12 years of practice taking care of professional athletes, we're able to give that same level of care and offer those unique skills to our patients, and so that the average patient can take advantage of what up until recently they may not have that availability. Our being a minimally invasive orthopedic sports medicine type of practice focuses on a lot of those types of procedures, and that would be procedures done with the arthroscope, meaning doing surgery with minimal incisions, which allow people a faster recovery and hopefully less pain. Some of those procedures may be arthroscopic meniscectomies, which would be going in and trimming or removing damaged cartilage in the knee. Something called chondroplasty, which would be going in and smoothing out rough cartilage and helping that not to be a source of pain for patients. ACL reconstruction, we talked about going in and reconstructing ligaments, and we actually are preparing to publish some of our research on allografts and ACL reconstruction, which allows less pain, less morbidity, meaning it doesn't require us to rob Peter to pay Paul, to take a ligament or a tendon from an area of the body and then reconstructing an already injured knee. We find by not taking other additional tissue that someone can rehab faster, and we have found that in our study to actually decrease the morbidity, decrease pain, and we have to date had no failures. And that's something that actually is very different than if people are out there and what I call reading or looking on Dr. Google and finding out that allografts were actually not recommended for young athletes because of fear of failure. And in our research, we have found that high-level athletes, including professional athletes, with non-irradiated, fresh frozen allografts, meaning tissue taken from a donor, actually has the same rate of failure as donor tissue. And I think that's kind of a paradigm shift in the delivery of anterior cruciate ligament reconstructive surgery, because up until now, most people would have a kneecap tendon or a hamstring tendon taken, and that actually has morbidity. There's complications with that. So minimally invasive procedures allow us, I think, to cause less harm to the patient and do a procedure which allows someone to return to their activities.
I went up for a ball and a girl ran into me and I just heard a pop, and I have had an ACL done 10 years ago, so I knew instantly. And so we did an MRI and came back in and found out that I did tear it. They got me right in. I mean, I went into surgery the next week. so it's like, I want to get it done as quick as possible to hopefully start running again. And now I'm running my first half marathon in 2 weeks.
I think that there are a variety of procedures that we do that just give great satisfaction. I really enjoy doing sports medicine because we truly have the ability to cure things and to get people back in their game, whether it be a sport or whether it be just the game of life. When it's something that we do for enjoyment, that's one thing, but when you're dealing with professional athletes where there's millions of dollars in contracts on the line, that's quite another thing. And so in years past, if we didn't necessarily have the ability to reconstruct someone's knee and to fix or reconstruct an ACL, then someone's career may be over. I think all of us are pretty familiar with athletes like Tom Brady, Philip Rivers, who I had the chance to work with in San Diego, who both had anterior cruciate ligament reconstructions many years ago and yet returned, and in the case of Tom Brady, certainly has won a Super Bowl since. Can't say the same for our quarterback in San Diego, but we have high hopes. Yeah, one of the questions that comes up is, spending a good part of my career taking care of professional athletes is, well, what do we do different for them compared to our regular patients? The truth is we don't do anything different. If you are someone that's, later on in years, and that really your activity consists of maybe going for light walks and you're not really participating in competitive activities such as basketball, soccer, or football, then for you, you may not need an anterior cruciate ligament reconstruction. Our patients that we see here at S.P.O.R.T get exactly the same level and type of care that we would give to any paid professional athlete. And I think that's something that probably sets us apart and compared to maybe other orthopedic practices, is that we truly try to treat our regular patients just like the pros. Certainly the experience that we have in providing elite level care for athletes, we use things that sometimes wouldn't necessarily have routinely been available, but we have in our practice made those available to our patients. There was a patient of mine who was playing for the New York Jets, and on Sunday Night Football, actually, the quarterback threw him a pass and he was clipped low and took out his knee, nearly dislocating it. I got a call later from the patient and his father, and within a week they were back in Texas and I had reconstructed his knee. The rewarding part of that is his career would have been over, but by getting him into surgery and reconstructing his knee, we were able to get him back and playing football at the NFL level.
I was with the New York Jets from 2011, 2012, and I suffered a knee injury. The first person I called was Dr. Berry, and had a torn ACL, LCL, bicep femoris tendon, meniscus, and also had to get a microfracture. So it was a pretty substantial job, so I know I had to call Dr. Berry right when I had the injury. I kind of saw from the very beginning to the end Dr. Berry's involvement and the high level of patient care, especially in terms of NFL. You know, it's such a small chance to get a shot the first time. It's even smaller the second time. I really don't think I would have had a second chance to get back at the NFL if I'd have went to anyone else.
I've had other athletes and pitchers particularly who had seen other team physicians and were not able to pitch in the case of a professional pitcher for a local baseball team, and was able to correctly diagnose his shoulder problem, rehab him, and return him to a high level of pitching, allowing him to return to the sport that he loved and was how he made his livelihood. So those are always rewarding cases when you can take someone whose career again would have otherwise been over, their ability to earn income, and then to return them to that sport and activity for them and their family. That's very rewarding. So one of the most common procedures that we'll do is something called a Mumford procedure or distal clavicle resection. That's something that's gotten attention recently in the media with Tony Romo and his injury. And what a distal clavicle resection is where we go in and actually shave a small amount of bone arthroscopically off the end of the collarbone so that when someone raises up their arm or reaches across their body, it no longer causes pain. In Tony Romo's case of having clavicle fracture and as a quarterback sometimes being sacked, unfortunately, sometimes too often when your offensive line doesn't protect you, it certainly for many football player is a source of pain. And so with that procedure for football players or other athletes, or our patients in general who just over time have developed arthritis, it's a procedure that gives great relief, and it's minimally invasive. It takes only a few minutes to do in the operating room, and then in a matter of 4 to 6 weeks, someone can return to full activities. One of the other procedures that we focus on are cartilage transplants, and really what I like to tell people, that's science fiction meeting reality, that now instead of having to replace a joint, we have the ability to actually take cartilage and, if you will, resurface an injured joint. In years past, someone would have had to get metal and plastic put in their knee. Not everybody is a candidate, but more and more people are as our technology gets better. So that's something that we focus on. Biologics are something sometimes referred to as regenerative medicine. People may have read or heard of terms such as stem cell treatment, or abbreviation called PRP, which stands for platelet-rich plasma. And essentially what that is allowing us to take things from our patients, not drugs, and actually concentrate their own cells or platelet-rich plasma and taking from their own body substances, concentrating them and injecting to sites of injury so that the body can heal itself. And that is something that really many orthopedic surgeons feel is going to be the next frontier in sports medicine, and that is the biologics of stem cell treatment in the future. I think one of the things that we pride ourselves is trying to be more of a concierge type of practice, and that is when people come in, we do our very best to say yes. We do our very best to follow the golden rule, and that is to treat others the way that we would want to be treated. We certainly understand that uncertainty with an injury and the fear that comes with that. And then when it comes to the surgery, if that is something that is required, what we try to do our very best is to meet patients where they're at, give them choices, inform them, educate them. Sometimes the financial aspect can be a hindrance for someone getting the care that they need. And so we develop programs in our office in order to make that affordable so that patients can get the care. So from the first visit to the time of discharge, when someone's back in life and doing the things that they want, we try to follow them along that process and support them to returning to life and making sure that we serve them along the way. I think for any particular injury or surgery, a good question for patients to ask their surgeons is, how many of these do you do? We use the football phrase of how many snaps under center do you get? How many times are you doing this? And for a lot of procedures, the more experience that your surgeon has, often the better he or she is going to be with that. And we do hundreds of ACLs per year, and we do more than many other surgeons in our area. in North Texas and across the United States. And because of that experience that we have, I think that our outcomes are going to be a little bit better. There's lots of research out there, particularly with joint replacement as well, and certainly with anterior cruciate ligament reconstructive surgery. And in our case, that's something that we specialize in, and we have developed our own techniques and our procedures, publishing our own research so that the public will be able to see exactly what we're doing. In our particular ACL study, we've had no failures with our technique that we have done, and that's something that very few surgeons can say. Certainly through our techniques and procedures and our rehabilitation protocols afterwards, it's allowed people to return to their activities, and I think that's something that I would put up against any other surgeon. And the last thing you want is to have an operation such as an anterior cruciate ligament reconstruction and then have it fail and then to have revision surgery. So instead of having it done right the first time, then having to have it done a second time. And we certainly know that revision procedures, so surgeries that have to be done a second time, usually the outcomes of those are not as good as if we would have just done it right the first time. So I think for patients, make sure you know your surgeon, research them, ask questions, know how many of those particular procedures your surgeon does a year, ask them about the techniques. I think another thing is to ask where your surgeon does those procedures. I think it's important that as a surgeon, the team around the surgeon is experienced as well. Because we do so many anterior cruciate ligament reconstructions per year, we have a team of experts that works with us and usually have the same team in every case. One of the analogies that I use with patients, and having treated many chefs at very nice restaurants around North Texas, we often talk about them coming to my house and making their same meal in my kitchen. And often they'll say, well, I'm a great chef, but if I was to make that meal in your kitchen, the outcome of that meal and of that special dish probably wouldn't be the same. However, if you come to my restaurant and in my kitchen, I certainly can make that dish to perfection. And so as a surgeon, we want to make sure that we do that procedure in the appropriate place and with an experienced team. And that way, our patients can be assured of getting the absolute best possible outcome. And that's what we do.